So this is the panel on bringing WHO smart guidelines to life in FHIR native apps. To quickly go over who this is for, so if you're a technology partner and are interested in using the smart guidelines, this is a session for you. And again, this is focusing on the L3 to the L4 layer. Sorry, I forgot to introduce myself. My name is Nat, Technical Officer in the Digital Health and Innovations Department, and I'll be your moderator for today. We have a great panel lined up for you, and so I think given time, we'll just go right into it. So the first presentation will be from our Google colleagues. Our first presenter will be Fred Hirsch, who's a Senior Product Manager at Google Health, where he works on data-driven mobile-first healthcare systems and translational AI research to address health equity gaps. A lapsed software engineer, clinical doctor, public health practitioner, and, quote, failed academic, he has experience harnessing technology to improve access to quality healthcare. He has been active since the very early days of telemedicine, back when 56K internet connection was blazing fast. And in that presentation, we also have Jing Tang. Jing is a software engineer at Google Health in London and the engineering lead of the Android FHIR SDK. In the past 10 years at Google, he has worked on a wide range of projects, including large-scale ad-serving pipelines and Android OS before starting the development of Android FHIR SDK in 2020. Prior to Google, he worked in high-frequency distributed systems in media and finance. He holds a master's degree in advanced computing at Imperial College London, and he believes an active and engaged developer community is the key to unlocking the full potential of open source software. So with that, I'll hand it over to you, Fred. And
can you hear me? Yes. Okay, great. Thank you very much. Thanks for the introduction, and it's really wonderful to be here. It's been an amazing couple of days, and it's just been so exciting to see all of the enthusiasm in the room, and really, really great to be here. So let me see how I make this work. I'm just waiting on the slides. Excellent. All right. So to introduce the work that we've been doing with the WHO, I just wanted to take a little step back and share how our team is thinking about this space. So it's really anchored around these three themes. The first around how do we help to address health equity gaps. Very much thinking about what's our role in supporting existing efforts towards achieving global development goals, and how does technology play a role in that. And I think this kind of underlying belief that we want to see that mobile and AI technologies, we know that they can be a vector for change, but how do we ensure that they benefit all? And I think that's something that's been echoed over the last couple of days as well. But as we know, there are many challenges. These are just some of them to really realizing the potential of mobile for healthcare. And this is really, the foundation of the work that we've been doing with the WHO. So I think kind of in keeping with the theme of this year's event, which is around driving effective and equitable digital health innovation, put simply, our team is working on, trying to, I suppose, answer this question or focus on this area of how do we help developers everywhere build what we think of as next generation digital health tools, right? To really accelerate this shift, which is very much underway, towards more patient-centric, data-driven healthcare solutions. Now, this is a bit of a gross simplification, but when we think about this, we think about, the theory of change is obviously far more complex than starting just with developers, but we believe that, we can really affect that change by addressing some of the pain points that we see that really kind of hold things back from achieving that scale that others like Vilas have spoken about over the last couple of days, right? So what we see is that if we can really reduce some of this technical complexity, bring down those barriers to entry for developers everywhere, this can really stimulate that increased innovation, which will ultimately lead to better tools for frontline health workers, more time freed up to focus on harder problems, focus on user experience more. and ultimately lead to better care for patients, right? As well as benefits to the health, the health system. And really what we want to see is a more like healthy, sustainable, equitable ecosystem emerge out of that. So so our team at Google and others actually throughout Google, we're building what I think we can think of as some enabling infrastructure for digital health. So these are technologies as well as associated resources that we're working on, both for developers and designers and implementers, to help them build, to provide these tools for building these next-gen solutions. And so today, we're talking mostly about the Android FHIR SDK, but we've actually been working on a few other technology components that I just want more to share with people to know that they're there. More will be coming, but we've got the Android FHIR SDK, which Jing's going to talk about in a lot more detail, the FHIR Access proxy, as well as some work going on FHIR analytics. And really, the way that we think about this is that each of these components solves for a different problem, very much designed with the unique needs of the constraints in which, frontline healthcare worker apps are being deployed or systems are being deployed. So the need for, offline capabilities, being able to, sync data, be able to run all offline. That data is often stored in on-prem environments, so there aren't necessarily opportunities for leveraging the cloud. So that's very much baked into the way that we think about this, and very much about enabling the adoption of open healthcare standards. So we're talking about FHIR and how can we help to promote interoperability, bring that ability to demonstrate patient-centric care, and really establish through better data foundations, the future AI opportunities. And so these components, whilst they can each be used independently, can also can kind of put together to have an end-to-end digital health solution or backbone for end-to-end digital health solution. And so finally, I just want to say we're also working on some UX guidelines, and as you'll see in the FHIR SDK, a lot of work's been, a lot of thinking into how can we, bring kind of some of our design strengths and capabilities and share that with the community and the ecosystem. So, code labs, sample code, and Jing will talk more about that as well. And just at the bottom of the slide, just to call out, the principles that really kind of guide the work that we're doing, very committed to open source and enabling, adoption of open standards. Today, we're focusing a lot on FHIR and how do we make those capabilities and how do we bring, content like the WHO Smart Guidelines and make that available on offline, online, on-prem and cloud, which I talked about, and really enabling this data-driven healthcare. So thinking about workflow and how do we tie things together to do coordinated care is kind of baked into the thinking. So just lastly, just to share, this is, as I was saying before, these components, we think of them as being foundational pieces that developers everywhere can leverage to really build the solutions or platforms on top of these, and we'll hear from some in a minute. This is just one way of thinking about it. There are many other configurations for this as well. As I mentioned, you could leverage, for example, some of the work around analytics that can be done independently of a FHIR native mobile-based approach. And we're certainly very excited to work together with partners throughout the ecosystem to showcase how these different solutions potentially come together. I'm going to hand over to Jing now to talk a bit more about the Android FHIR SDK specifically. Thanks.
Cool. Thanks, Fred. Right, so I'm going to talk a little bit more about the Android FHIR SDK work. So this work was started almost 3 years ago as a collaboration between WHO, ONA, and Google. So the goal of the SDK really is to help developers, enable them to build Android applications that are at scale, that are offline capable, and also leverage the standard, which is FHIR. So there's 3 main goals we're trying to achieve. So first of all, obviously, the FHIR is at the very center of the SDK work. We want to accelerate the adoption of FHIR. And also, secondly, the support for digital smart guidelines that WHO has been championing is a very important goal for the SDK. And then in the future, we want to get to a point where the SDK is a delivery mechanism for the AI capabilities and the more smart future capabilities that we have. I want to also call out here that the SDK has been recently recognized as a DPG, so you can now find the SDK in the DPG registry. This is something we're really excited about. So I'm going to talk a little bit about the benefits to developers. I think first of all, we want the SDK to be something that you can try to start adopting FHIR if that is something you want to do. The common data model is there. We have the capabilities for you to start using some of the tools to use FHIR very easily on Android. And then the second benefit to developers is that it will save time and effort. It's really important that we provide, we can solve real pain points for developers. And I think it's really important, it's really cool that at this conference that we heard from some of the early adopters where they talked about their the cost saving in their projects. For example, like Steve Vonier's group, they talked about they saved 4 months of time using the Android FHIR SDK in their development. And then finally, the leveraging of the advanced capabilities is something that would be a great benefit to developers as well, especially the CQL work and the smart guideline work by WHO. So talking a little bit more about the architecture of the Android FHIR SDK libraries. So there are 3 main libraries that we're currently developing. The first one is the SDC library, which enables the collection of FHIR data on Android phones. And then the second one is the FHIR engine library. So that will handle the storage of FHIR data on Android and the synchronization of it with the FHIR server. And then lastly, the workflow library, which is in alpha stage, is the library that enables decision support on Android using CQL and the smart guidelines. So on the right, we have a diagram. It's a very simplified diagram that kind of shows an example of how you may want to put together an Android application using the SDK. So, you can build your custom application logic on top of the Android FHIR SDK, and then the SDK will handle the data capture, the storage of FHIR data, and the workflow capabilities. So I just want to call out also here, these libraries are building blocks, so you don't have to use all of them. So you could really tailor the usage of the libraries to suit the needs of your application. Right, so I want to talk a little bit about the developer resources we have developed. So we have 2 example demo apps. The SDC app to demonstrate the SDC libraries capabilities in rendering UI, and the FHIR SDK demo app that puts together all the different libraries together. And then we also have the wiki documentation, which is on the GitHub website, and also we are developing a set of developer tools and code labs to get you started. Quickly talking about the partner ecosystem, we have a relatively small but fast-growing set of developers and technical partners building solutions for a range of different health programs, all starting from the SDK. You will hear a bit more about Onur's work and the YamCare work from Matt and Ritika. But here we want to call out especially the work done by Stephen Wangney with the IntelliSoft team, who they have been presenting at this conference. But also we want to give a shout out to the IPRD team and their work in the Oyo State and Osun State in Nigeria, together with Hasey. So just a little bit more on the impact health work by IPRD and Hasey. So in November this year, they launched this app. It's a FHIR native app on Android for covering ANC at the facility with integrated malaria RTD screening. It's been deployed in 2 clinics, and the team is working to scale up to more clinics. So I will talk a little bit about the open community. There's many different ways to get involved with SDK development. We are participants of the WHO implementers call every Tuesday. We also run a developers call on Thursday. We have sort of the groups that I mentioned who frequently attend these calls. but also you can reach out to us on Zulip or email us at android-fire@google.com. So on the right is the sort of the logos of the partners we work closely with. Thank you. So if you have any questions or feedback or interested to learn more, you can also directly reach out to Fred and myself at our email addresses. Thank you.
Thank you so much, Fred and Jing. I think if everyone could hold their questions till the end of the panel, we'll just move on to the next presentation from Ritika, who will be presenting some work that WHO is doing with the MCare project. Ritika Rolani is a consultant in the Department of Digital Health and Innovations at WHO. She's a biomedical engineer with over 10 years of experience entrenched in healthcare and technology. Ritika has worked with interoperability and use of HL7 standards for data exchange for EMR systems, health information exchanges, and personal health records. She has led several NGO and INGOs to adopt scalable designs for impact management systems that support evidence-based decision-making. Ritika holds a BE in biomedical engineering from the University of Mumbai and a master's in healthcare management, economics, and policy from SDA Bocconi in Italy. Over to you, Ritika.
Thank you. So I'm excited to present bringing smart guidelines through life through this app. It's always nice, like Jing also in his presentation showed some implementations that are out there on the field. So it's always nice to see something in real, an app that's out there. So I'm very excited to present MCare, which is a mobile app that is supporting the use of WHO recommendations in emergency settings. So what is MCare? It's a mobile app, a digital platform that will be delivering clinical guidelines at the point of care in emergencies. So in humanitarian settings, maternal and newborn and under 5 account for 50% of the mortality. So that was one of the goals and scope to focus on maternal and child health in emergency settings. So what we've done in MCare is adapted the IMCI guidelines, the severe acute malnutrition guidelines, and the newborn care guidelines into this app. So MCare represents a partnership with over 30 organizations, including UNICEF, UNHCR, ICRC, SwissTPH, World Food Programs, MSF, TERS, DEOMIS, and more. So MCare will be piloted in fields in early 2023 in Iraq and Cameroon. So a little bit more about what we wanted to achieve with MCare. First and foremost, of course, to improve health outcomes for mothers and children in emergency settings, to empower the emergency healthcare workers to treat and refer patients at the point of care using guidelines that are recommended by WHO. In keeping with the SMART guidelines objectives, to make sure that even at point of care, we are maintaining fidelity with the WHO guidance. And then to promote a reusable ecosystem which member states can contribute to. I'll speak a little bit more on that in my next slides. And then finally, contributing towards universal health coverage for all. So SMART guidelines has been presented a lot in the last 2 days, so I wouldn't go through from L1 to L5, but essentially MCare is not just the app at L4, but a series of methodology that was followed right from the L1 guidance through to L4. So at the L1, the IMCI guidelines of the severe acute malnutrition and the newborn guidelines were adapted for emergency settings in consultation with clinical experts from UNHCR, ICRC, UNICEF, etc., to adapt to be what would be the right guidance for emergency settings, which were then drafted as a DAC in L2 with business processes, decision support logics, what workflows would be needed, and then written out as a FHIR implementation guide with CQL decision support in there in collaboration with SwissTPH, and then finally made into an app with Argusoft, which is a mobile app that can also support offline use as an L4. to dive deeper into this, getting to an L4, because I've had a number of people ask me in the last 2 days as well that it's fine to write FHIR IGs, but will we ever be able to get to an app? A little bit more clarity on how we got there was, of course, the guidelines were adapted, the business, decision logics or business processes were written down, FHIR IG with CQL and FHIR. But then when we get from L3 to L4, you see the underbelt there, which was really key in getting us to an L4, which is the ecosystem that even Fred and Jing have presented. So the Android SDK was leveraged. FHIR APIs are needed for the web interface, terminology services to make sure that the consistent terminologies are being followed. And for app needs like user authentication, user login, etc. So Keycloak was leveraged for user authentication. And then we also have Happy FHIR server there. So these are the, what I want to call out and get attention towards is that getting from an L3 to an L4, the key components were also this ecosystem of tools that are out there, which we have starting a few, but we need more of and more development towards, that these tools helped us towards to getting to an L4. On the L4 side, MCare is just one, right? Like we've been saying, WHO wouldn't recommend the product in a sense, but the ingredients behind the product. So MCare is just a representation towards what could be possible through smart guidelines, but also because it was an emergency setting, WHO has to be a provider of last resort. But not to say that countries are supposed to be using this MCare as a product, but also, but to say that they could actually adapt and contribute more towards this app and then build their own customized version of it using this ecosystem of FHIR IGs and the SDK and the tools that are out there. I also want to call out to OpenSRP, which Matt would be presenting next, but that's also built on these FHIRCore components that can be then customized to get us to an L4 app. So there could be many versions, variations of this L4 app, which look like MCare, deliver the same health and data content, but doesn't have to be MCare. Let's look at MCare a little bit. So I just have a high-level architecture diagram. So on the left, yes, on the left you see the mobile app, which is leveraging a lot of the Google SDK with a local database that is doing registration, decision-making, a lot of other features which I'm not able to read right now from the screen. And then finally, then again using the FHIR SDK to sync with the server, which is a Postgres database, and then pulling it onto a web interface which has features for role management, indicators monitoring, and other needs. A few screenshots from the app. So this is the login page and the list of patients. I think this is all also leveraged from the Android SDK. You saw that there were similar screenshots from Jing's slides as well. So again, leveraging a lot of features from the Android SDK itself, adding a new patient or going into assessments of danger signs, and then a few screenshots from the web platform. So speaking to BIT, of course it wasn't an easy journey, but rather than challenges, I would call like what is paving the way for L3 and L4. Clearly, adopting HL7 FHIR in the LMIC settings is new, and therefore MCare is constantly requiring some support from the FHIR community and from Google. And then, of course, further investments are needed in infrastructure to have more and more such tools that are doing creative, these common tooling that's there. Also, we are also looking at further investments in tooling that could probably automatically publish L3 FHIR IGs from L2 DACs that are written. And then also support to add more and more functionality in the FHIR SDK for more FHIR resources to be supported. We're also looking at investments and needs around capacity building so that we have, we can probably empower more and more developers to author FHIR IGs and then implement FHIR native apps, around governance for these core components that are outside of the SDK. And then, of course, calling out to the community to contribute and share their experiences. And I think Jing had the slide on, we have these calls on Tuesdays and Thursdays that are contributing to this community. So Please share your experiences and challenges so that we can together learn as a community and grow more on this effort. Thank you.
Thanks so much, Ritika. So maybe just to quickly summarize, we've heard from our Google colleagues about developing core infrastructure that's really needed for this work with the Android FHIR SDK. We've heard from Ritika about the work of developing the smart guidelines in and of itself, including the L4 reference software. And now we'll hear from Matt, who will provide an overview of how they've shifted from OpenSRP to FHIR. Matt Berg, as a co-founder and CEO of ONA, which is a technology company dedicated to using data to transform lives in the global health and humanitarian space. Prior to founding ONA, Matt served as the ICT director for Minority Research Group at Columbia University and was the country director for the Geek Corps Mali program. Matt is a PopTech Social Innovation Fellow and was named to the 2010 Time 100 list for his technology work in Africa. Matt also taught ICT 4D at the School of International and Public Affairs at Columbia University, where he was adjunct faculty. Matt has an MBA from the Dunbar School of Global Management. And over to you, Matt.
Is it on? I should have reviewed that. Well, good afternoon, everybody. My name is Matt Berg, and I'm going to talk a little bit about kind of our experience kind of working, kind of getting into FHIR. And I'm kind of talk about it a little bit from the perspective of somebody leading an organization that's been developing actively a platform over 8 years. At that time when we started the FHIR journey, had achieved global good status and achieved adoption at kind of big scale. So our platform is called OpenSRP. When we first heard about this kind of idea with WHO and Google, it was kind of, we met in Milan, and then right after that, COVID happened. It was a good time to be introspective. And I was looking at kind of, what am I doing with my life? My kids were screaming in the background. They're cute, at least. And we're thinking a lot about, if I'm looking, if I really am introspective about what we're trying to do, am I actually, do I want to spend another 10 years working in digital health, but fundamentally not offering something different to governments? Because what I mean by that is, I see that governments are, we've gone from kind of proof of concepts, we've gone from kind of, is digital health, does it work? Yes. Is there evidence? Yes. And now countries are eager to move forward and scale nationally. And if I looked at what we were doing, I don't think we fundamentally address, we might be a nice UI, we might have nice features, but fundamentally we're not any different than anybody else in this, addressing this ecosystem. So what I mean is just kind of give you a bit of context. This is sort of the way that digital health works right now. If you have any app, you basically have a UI, you have your app logic, and you have your data model. Okay. So if I'm developing, say, an antenatal care app with platform A, I'm going to have to invest a lot of time to build that logic. If I'm a Ministry of Health, to build that antenatal care module. So I'm investing in that app's or that platform's proprietary logic model, and then the result of that is proprietary data. When I say proprietary, it doesn't mean it's not open source. It just means it's based. It's kind of the format of that platform. So I'm actually starting to make a 10-year decision because I'm starting to collect data and I have all this information in that format. And then you get different donors and different platforms in a country making similar investments, and that's kind of, we see these stovepipes that happen. So it's not, anything that is by design bad. It's just the way that, the system works. And we have these proprietary data models. You have to connect them with custom adapters too. So yes, it's possible to have interoperability, but it's very expensive and it's very fragile. And we don't get the kind of the natural interoperability, kind of the sharing of data across systems, the patient-centric approach we want when we're talking about, I think, kind of addressing digital health more at a systems level. So what's really exciting about what the colleagues here have presented today is with the introduction of FHIR and the especially with the introduction of the FHIR SDK, we have the ability to apply FHIR in a new way that I think is really exciting. So with FHIR, what we've done with OpenSRP, I missed a bit about, we decided to throw our platform out and start from scratch. So over the last 2 years, working with Google and IPRD, WHO and others, investing in the SDK, we were able to rewrite our platform. And the result of that is now we have the ability, just like MCARE and IPRD and Stephen's platform, we have now ability to have a standards-based app logic and also a standards-based or shared data model, which is really, really powerful. And then you can so it's kind of the idea of kind of Lego blocks. The other thing that we're really excited by is we don't have to write all the logic anymore too. WHO, which, doing the logic is very expensive. So that I think the smart guidelines really, even just knowing like, is your logic right or not is really, really hard. So WHO is going to take on the burden and the investment for governments to do that authoring in a kind of executable way. One of the ways we've been describing it to people is kind of like MP3s. Back in the day, the MP3 wasn't the first way to listen to digital music. We had waves, we had all these different formats. But once we finally agreed on a format to do, which is what these guidelines represent and FHIR can do, you can start to invest in different players. So we now have this ability to have standard logic that can run across a bunch of applications across a shared data model. And we kind of have learned a little bit firsthand. So this is a work we did with WHO, with Nad and Garrett and team, trying to kind of build kind of the first pre-DAC, or before the smart guide. I think we were the influence by being a pain. So we spent about 2 years trying to program the antenatal care logic. It's a huge app with a ton of logic, and we're using it now, and we still have a lot of bugs in it. By having the guidelines, we can basically reduce a lot of those problems. So OpenSRP basically is the ability to leverage the FHIR SDK, the smart guidelines, to offer, you can have a new generation of tool. Just some of the benefits also from kind of more on the technology side. So one of the first things that we benefited from is that the SDK, which Jing was discussing, comes with a beautiful kind of form renderer. So you have the ability to kind of start to do ODK-like forms. And I'd also like to call out that in a lot of ways, this is sort of like the beginning of like an ODK-like ecosystem. So having even a way just to represent a form with skip logic is really, really valuable. So very small incremental, building blocks we have here. So I think the fact that this was the main focus is really smart. And so this is kind of what we're building. Our first application on top of the SDK is a community health worker app. We're rolling this out in Liberia and in a couple other countries early next year. And then the other thing that's really exciting is also what we don't have to do. So the nice thing about FHIR is the specialization and ecosystem. So all our team has to worry about now is the thing on the left, the Android app. We actually were able to throw out our server, which is awesome. Which if you write software, it means a lot less people you have to pay, which is great. Also, the other thing was we have the first time in our life where we're working with the Ministry of Health in Uganda, and they're running a Happy server, which is a FHIR server for Iris, which also uses Happy. So we don't even have to set up a server. We're just going to plug our data right into their system they're already running. So that's a huge kind of win. So that the decoupling also for the Ministry of Health can say, hey, I don't need to, I can pick my vendor for hosting. I can pick, Google. I can do whatever I want and do it there. And then not be locked into a specific solution provider, I think is really exciting. But there's also a lot of pieces that are missing, like we have to build a web interface, all those things that you expect to have. This is an ecosystem tool. But the nice thing is different groups can specialize, like the Norwegian Health Institute has built a great tool for form authoring, kind of like a WYSIWYG for doing the questionnaires. So there's a lot to benefit. And then we also get the interoperability. DHSU has a FHIR adapter, OpenMRS has FHIR adapters. So those frictions are also decreasing. Sorry, almost done. The last thing I think that's kind of really important is also kind of what it enables. So that the nice thing about the smart guidelines are we can start to package up all these modules, all that logic, and build a primary health facility app that does that. I think one of the reasons you don't see that happening now is it's just too much work for one country to invest in. So the ability to have these packaged MP3s that I can put together in a playlist and run at a health facility is, I think, really, really valuable. And then the last, probably the most important thing is just that what it enables also is continuity of care. So thinking of health from a system standpoint, where you have a shared data model across, your community health workers and your health facilities, for example, for child immunization. EIRs get a bad rap because, they're not going to increase vaccine rates if the kids never show up at the clinic in the first place. So if you have to, but we also think of them as EIRs and community health systems. We don't think of them as immunization systems. FHIR basically reduces the friction to make that possible. And then I think it also applies to other areas like microplanning, which we do a lot of work in. You can represent microplans in FHIR, something I'll be bugging you about next year, hopefully, at this conference. Yeah, and just to call out, this is ready, but we're bringing it to scale. And I also just wanted to mention D-Tree. And one of the things I'm really proud about our partnership with D-Tree is we've worked with with the Ministry of Health in Malawi, with a local engineering team that they have on the ground, and we're building, using OpenSRP, the new version, an application adapted for Malawi with Malawian engineers, because that's another, I think, key thing. This really does lower the barrier, like Stephen Wanya mentioned. He was able to get an app off the ground in a couple of months, and if you had to build this all from scratch, it'd be a couple of years. So it's really going to be this idea of enabling local tech ecosystems, this kind of SDK work is really, really powerful for that. And I'll stop there. I think there's a lot more to go, but the last thing is, it's not just about what FHIR can do now with the interoperability, it's also what it's going to unlock in the future. So it's going to make things like portable health records possible. It's going to enable us to use applied AI. AI right now is based on research projects because we don't have standardized structured data. FHIR is going to generate that, and the workflow support for tasking and all that. So there's so much possible if we adopt this ecosystem approach in terms of what's possible in health that this is going to enable. So it's very, very fundamental, and I'm really excited to be part of it. Thanks.
Thank you so much, Matt. I think you made a really great case as to why FHIR native apps versus, say, only being able to exchange data in FHIR, with not only the immediate reduced time and resources to building content, but also the fact that there's a lot of potential behind that. So with that, maybe we'll open up to questions from the audience, if any. Yes, Peter.
Thanks, Matt. Question for Fred or Jing. As some of us may know, FHIR is an ever-evolving standard. Is there a vision or a strategy to live with these changes in the future? As I believe R5 is coming out next year, so just wanted to get your thoughts on that.
Thanks for the question. So so when we started building the SDK, we were looking at obviously R4 version, and we do have dependencies on R4 structures in the SDK. But since the release of R4B and then R5 coming, we are actually right now undergoing the work to make the SDK capable to handle different FHIR versions. So that work is already is already underway. We are expecting to be able to do that in the coming months. Yeah.
Merrick?
Merrick Schaefer, USAID. All right, so it sounds like we need a lot more people who are developers who can play in this ecosystem. Are we ready? Do we have the resources if we wanted to start doing boot camps in Southeast Asia and Sub-Saharan Africa and Latin America? Are we actually there? Do we have the tooling? Do we have instructors? Do we have that thing? Do we need to build that?
I don't know who in the panel wants to answer.
I'll take a stab at that first. I mean, I think it's, so thank you, and that's great. I mean, I think if we're definitely getting to that stage, I think, and I think what's been really exciting about the last couple of days is, you know, meeting all of the people for the first time. As Matt said, a lot of this has happened kind of during COVID, and getting kind of the initial kind of group of people together, but then also, you know, meeting other groups that are like really interested in this and starting to kind of get that sense that, okay, like, yeah, let's kind of start mapping out what does it take to kind of, you know, establish that capacity and kind of, you know, bring more developers to this. And so, you know, on our side, you know, we really want to see adoption through those types of channels. And so we're, like Jing presented, you know, producing code labs, you know, trying to make sure we've got great documentation, you know, giving, you know, making it as easy as possible. And I think wherever we can, you know, we want to kind of take the opportunity to, you know, to like lean into those opportunities. So, you know, I think we were talking to Stephen about what's going on in Kenya and potential for connectathons. But yeah, I think like, so I don't know that we have the academies and everything set up, but I know like WHO is also thinking about, you know, how do we get some of these courses? I think we've got to, as an ecosystem, really think about how do we pull our resources together? You know, what are those needs at different levels? And how do we kind of start taking the opportunity to make sure that whenever we're engaging together, like we are running some kind of tech, you know, boot camp or workshop or things like that. So, yeah.
Any other questions? Yes.
Look.
Garrett, and then, I don't know, then Matt. Oh. Okay. Thanks.
Hi everyone, my name is Jibril Kamara. I'm a USAID medic. The question is about clinical guideline, practice guideline. Is looking at in practice, you know, it might be a conflict between clinical guidance. You know, we know patients, some patient might have multiple conditions. For instance, even if you look at malnutrition, you know, you caring for malnutrition, but it could be the fundamental problem for other clinical condition, because the patient are suffering for that, it might be developing a respiratory condition and so on. My question to you, did you select that because it's like straightforward as use case for using these clinical guidelines for like the piloting? Is that the selection of that specific use case is because it's straightforward, or what are your thoughts about like moving down the road? I'm sorry. What are your thoughts moving down the road, as probably my plan to use these and expand in primary care, where patient might present with multiple conditions? I want you a little bit to expand that. Thank you. I'm sorry I had a mask earlier. I don't know if I was clear enough. Okay.
Ritika, do you want to take that?
Yeah, I think, no, I don't think the choice was because it was straightforward, but I think the objective for WHO is to make guidelines, WHO guidelines available in a machine-readable fashion. So that was the choice. But the question or the conflict you bring up is very relevant, and I think we have been internally in the team also debating over the same questions. Prima facie, my initial thoughts are that where there are conflicts, the system shouldn't be deciding for you, but rather not giving a decision, but giving a question where the doctors can actually then step into the clinical setting. So we have discussed like, this should happen for a sick person, and this should happen for diabetes, and this should happen for pregnancy. But what if it's gestational diabetes? What should you do? So where there is no guidelines right now, I don't think the system should be writing an algorithm to decide what should happen, but rather making sure that it stops at that time and then asks for manual intervention. And that's my thought.
Thanks. I think question here, and then
Maybe just a question to the panel. If someone in the audience wants to get involved as a developer, can you maybe provide an overview of how someone can get involved? Thanks.
I think so. If anybody's interested in getting involved, either as a developer or kind of understanding, I suppose, other avenues of engaging, and you can reach out to both Jing or I, but certainly on the developer specific. Do you want to just? We had a slide up before, but we've got an email address. Do you want to just? Yeah.
Yeah, so we have some meetings and calls we run, so some of them led by WHO, we're part of, and also we have one on Thursday every week. So yeah, or you can just directly email android-fire@google.com, and that will go to all of us.
And just to say, I think all that information is also available on the GitHub page. So if you go to github.com/google/android-fire, you'll find a lot of information there. Make sure to go to the wiki. Okay, someone's bringing the slide back up. There you go. And if we can go back, I think just, yeah. So there's the details of the different calls. And feel free to reach out through that email address. And that QR code, please scan it. That will take you to the GitHub repository for this work.
And just quickly to add, in addition to this, was just mostly focused on implementation and the Android SDK. If anyone's actually interested in creating the smart guidelines in and of itself, so the machine-readable guidelines, just let me know, and I'll add you to the Monday calls, which happen at the same time as well. But that's focused on the authoring of the smart guidelines. Matt.
Thanks. Hi, Matt Hulse with the World Bank. Great presentation. I have one question in two parts. It's about adoption. So the first part is how to measure the adoption of this approach. I think on like the quality side, there's the smart guidelines, which is that they're adopted with a sufficient quality or meeting the mission of quality healthcare delivery. But on the scale pathway, is there what are your thoughts on beyond just more apps, in the ecosystem? What's a great way to kind of track the adoption? And so the second part of that question is, a lot of the competing data models that have some of the integrations, like our aggregate data models in DH2, or maybe financial and billing, et cetera, they've spent, 10 years, 20 years, also investing in those models. And, how can you out-adopt some of those models? Because they're going to be continued to be invested in. And I see the potential in kind of the app marketplace, but maybe that's my challenge is there a story to tell in the examples to date, or in next year, or in the next 2 years, of rapid adoption that could show how it's competing with some of those legacy, but still relevant and important data models? Thanks.
Maybe I can take the second question first. I'll have a stab at this, because I think it's really important that as we move forward, as a community and kind of in the digital health ecosystem, I mean, there are significant investments that need to be preserved and need to be, that will have an important place, in digital health going forward, right? It's not about this approach versus, I think, a different approach. There is going to be different paths towards, I think, achieving interoperability, as Matt pointed out. There are other ways, and some of those ways, are fine for certain things, and being able to exchange data or transform data between systems for exchange, etc., might be a very viable, path for it. And so I think that's where, when we think about the different components, so we've spent a lot of time talking about the Android FHIR SDK, but this is also specifically why, at Google we've been thinking about what are the other, enabling infrastructure. And I think, the work around analytics and areas, and thinking about, well, okay, if I can start to converge around a standard, well then are there other capabilities that can really kind of bring value into the ecosystem there? And so you can imagine scenarios where which there are other types of community health worker apps that are not going to necessarily change to a FHIR-based data model, but may transform data into FHIR. But then you've now got the potential for a shared health record. So the investment then becomes in that transformation part. I've got a shared health record, but then I can also do some of the advanced capabilities on top of the analytics pipelines, because now it's all kind of running using a common schema effectively. Right? So I think that's the way that's at least the way that we're thinking about it. I think on your first question around measuring like scale, was that the question? I mean, I think I don't think we're looking to have necessarily, I don't think it's about, you know, how many apps have been put out there, but I think again, it's about, you know, I think as a community, it's around how do you measure the adoption of FHIR and the scale that that's starting to have. So are we starting to see like national scale deployments where FHIR is being, you know, weaved into the enterprise architecture? And I mean, I think the important thing about tooling like the SDK is that it also potentially allows us to think just a little bit differently about, you know, instead of having an application that does all of these things, you know, I might also start to have, I might actually want to have some kind of, you know, point applications that are there for a specific reason, but now local developers can build those that can be kind of plugged into, you know, a wider architecture that's now, again, based on this standard. And you start to imagine, you know, that's kind of the, you know, the way API-driven development has kind of led to, you know, less kind of monolithic kind of systems and more kind of, you know, single applications for, you know, to meet the needs of that specific use case. So, you know, I think we want to mostly see how that kind of plays out from an adoption perspective as well.
Just to also follow up, I think with, so this panel I think is about bringing FHIR to life, and I think we're still at this phase for most people that FHIR is kind of a concept, you know, like interoperability is a concept we've been talking about for 10 years. And this is really about bringing it to like creating that first utility to start to actually like have a reason to use it. And it's really after that, it's a journey. It's like, it's a shared way to think about health. You start to understand the problems it starts to solve. So for me, it's more about when people find some initial applications, you start seeing countries developing profiles, which is like basically, how do I represent a patient across and saying all apps have to use that profile? That's, for me, would be the sign that we're getting traction.
If I may, I just want to add that to sort of on the topic of adoption, right? So obviously, the adoption of FHIR is something that we think about, but also, at the end of the day, we want to provide, eventually reach better kind of care outcome, right? So the belief is that if we can help developers build these apps using FHIR, they can be more easily build another FHIR app in a different vertical, and then they can roll out their program using kind of having start building that patient-centric sort of data model, and that would drive the better care delivery. So I think that, to a lot of us, is even more important than just adoption of FHIR.
Any other questions?
Hey, wow, it's powerful. Daniel Messer from PSI. Just want to thank you also for fantastic presentation. Very emotional for those who worked in this a long time. I have the feeling we are finally doing the right thing, having invested for so much into the shiny front end and now looking a little bit more what's under the hood. Interoperability is, of course, a huge driver for us, and because we have wasted a lot of resources over the years. Question, I guess, is for Matt. At the very end, you said one word, which is portability as well. So how far do you think we are from solving the quest for so many different instances having access to someone's data, but not the client, her himself, and which opens a lot of avenues now with also the portable devices that we have and so forth. So where do you see, is there something in here for the end game on that respect?
Yeah, I'm going to answer briefly and actually hand it to maybe Garrett can mention because he's been driving the work on it. But yeah, I mean, the really cool thing is, you know, your vaccine certificate, that actually has a summary of a FHIR health record on it, right? So we have the ability to empower you no matter where you go. A mother to have access to her child vaccine records, an immigrant who's crossing across country. So that's, I think, hugely enabling. So yeah, and also the ability to read it offline and transfer it. There's just a lot of value. But I don't know, Garrett, if you want to mention that, or the trust piece especially.
Thanks. Yeah, so I think the International Patient Summary gives patients, it empowers them to take their record and to form the basis of interoperability between a facility, between a provider, and even across countries. so many, so much personal data is locked into systems, and patients don't have access to that. The COVID certificate is the first instance of globally an attempt to define the minimum data set, the minimum structure, and the trust between borders that this individual who's carrying this record, the vaccine or the lab test result came from an authorized authority, and that I can trust it in another location. That trust becomes really important. We call that a trust architecture, and it's at the foundations in paper form of things like the international health regulations, the yellow card that's used for yellow fever, the yellow vaccination card, many people know of it as. And I think what we're trying to make sure is there's the potential for a digital equivalent, and the vaccine record becomes the first instance of that, but it also becomes the basis for a summary of other records, and I think it's a really exciting future, especially for patients who have always been locked out of their data, and that's a huge change, and you know, we're hoping to make it possible through FHIR, because the International Patient Summary is a representation of FHIR. So if we can get the frontline worker and the health system data in a standardized format, then the patient can take their record with them. Thanks.
Great questions. Any more? Yes. Oh. You're next.
Oh, yeah, thank you again for the great presentation. So my question, the way to implementing FHIR, we know some of these countries have already their own system. Is there, I don't know what your experience or your thought about implementing FHIR facade? You know, that can be on the top of the system, will facilitate it, instead to have a new kind of FHIR server to start over. I don't know, any thought if you can share?
I could share one example. So I think it's, you know, what I presented, for example, is not going to always be feasible for all groups. And we have a case in one country where we work where there's 2 different platforms. We're one of them. The government wants that to be unified. So one of the nice things about FHIR is we can say, let's agree on the format. We can both put our data in the shared health registry or shared health record. And then the government then has one data warehouse to build and one set of dashboards across both systems. So there's different places where if you agree on the data format, you can start to create value across the different systems to help make it more manageable for an implementer. So that's like one example we see. We see the analytics piece being one thing that could add value to any system that's out there, even if they're not going to be quote-unquote FHIR native in the beginning.
Great. I see we're almost at time, so last question.
Right.
Yes.
Well, thank you for the presentation. My name is Bilal, and I'm from the Bloomberg School of Public Health. When I attend this conference here, I understand the demand for interoperability. But when I work with my public sector clients back in Pakistan, I struggle to sort of, create that demand. There is sort of more short to medium term thinking. They just want to get things done. Most of the developers are sort of using PHP and other kinds of sort of languages. And I guess this is a question for WHO, but keen to also hear from the folks from Google. How do you create demand at sort of national level, health departments for this kind of work, where there really isn't sort of much value into how the building blocks can sort of create something bigger, and they are just focused on getting things done in the short term?
Rachiko, do you want to answer that? No? Okay. No, that's a great question. I think the reality is we've seen both. So we've seen conversations with ministries where we've had to say, look, like if you don't invest in interoperability now, you'll have enormous sunk costs in the future, and they'll end up having to do it anyways. And then we've actually also seen ministries of health themselves experienced that, where they didn't invest in interoperability standards and are now finally realizing, oh, wait, we actually need to do this. Because if you look at most countries, low and middle and high income country, like there's so many systems in place already, but the reality is they're not really fully realizing the potential of what digital solutions can do and being able to access all that data. And so they're like, oh, how do we actually do it? And then it's like, oh, well, actually, there's something called interoperability standards, and this is what the value add is. And so depending on who you're talking to within the ministry, too, I think it's important to kind of tailor those conversations in that way, because if you talk to the clinicians, the point of continuity of care and allowing patients to have access to their data is of critical importance. But when you talk to M&E people, they're just like, we just want the data. And so you'd have to actually tailor it to that conversation. And I think there's a lot of cases to be made around interoperability. I think the critical piece, though, is to not go into the technical details, but really talk about the end outcomes of what you can achieve with interoperability, because there is so many things you can do. I don't know if others want to add.
I mean, I think the only thing, I think was a great answer. The only thing I'd add to that is that, so, I think in these early stages, what we really want to see is the demonstration of the value of FHIR, right? So kind of interoperability is a benefit, but it's not the thing that I suppose people imagine they're investing in. So as Jing mentioned, it's, how does this solution kind of deliver more coordinated care? How am I kind of moving from this, siloed programmatic approach to kind of something that's more patient-centric? And so having those kinds of demonstrations, building the, I suppose the case studies and other things around those will become really important, as well as the education around kind of why kind of open standards and why FHIR and things is important, because FHIR is, not if you look at it in the healthcare sector and in the technology and healthcare sector, it's really being embraced very widely. And so it's not a fringe standard to kind of, should maybe kind of learn about that, but rather anybody that's really starting to think deeply about building healthcare, technology, kind of needs to understand that, and we need to make the tooling so easy and simple that, it kind of creates like PHP, I suppose, in some ways, if I'm, doing those workshops, not just with people thinking about enterprise architecture, but, developers who are thinking about solving these health problems, getting them excited about the value proposition around the tooling, because it helps them to build, a better application at the end of the day. And I think that's the job ahead of us to some extent.
Great. And with that, we are unfortunately at time, and I'm sure everyone here wants their coffee break. So if we could have another round of applause for our panelists.